Hey everybody, welcome to another edition of the Migraine Mentors Minicast. I'm one of your migraine mentors, Dr. Erik Reis, and I'm excited to be here today to just give a genuine rundown about what makes a migraine a migraine. And gosh, we've been putting this newsletter on for a year plus, and every time we kind of put something out, we get our ideals and our kind of methods challenged a bit. But as you know, and if you're somebody who struggles with migraines, it's not just a bad headache. And this is just such a classic common misconception from so many people is that, oh, I've got a really bad headache. Oh, it's a migraine. Well, actually, that's not true. Another misconception is like, oh, I don't get auras, so I don't have migraines. Well, that's technically not true either. Only 30% of people who get migraines actually have auras. And so I want to kind of dispel some myths today, but I really want to talk about like what actually makes a migraine a migraine. Because a migraine is actually a really complex series of events that happen neurologically and then vascularly in the brain and the nervous system. And this can be triggered by things like hormones, by stress, by fatigue. They can feel like they just kind of come out of nowhere. For a lot of females who struggle with migraine, these things can be premeditated by just menstrual cycle issues. All these things matter a lot. And so I want to just kind of talk about some of the big reasons why what makes a migraine a migraine. And so the first thing is this whole neurovascular cascade. So, for a long time, migraines were thought to be vascular. And then after a while, they were thought to be neurological. But it turns out they're both, right? But what I can pretty much take to the bank is that everything is controlled by the nervous system. So, yes, it's a neurological condition, but it's a neurovascular condition specifically. What that means is that the nervous system alters or controls the vascular or blood flow inside the brain. And so that's a really important factor for migraine. It's a neurovascular disorder specifically involving the trigeminovascular system. Whoa, that's a big term, right? But what I'm talking about is the trigeminal nerve, this nerve that actually sits on the side of your face right here and over on the left side as well. There's different branches. There's a first branch, your second branch, and your third branch. And these all kind of converge into this little nucleus right here. And it kind of comes in and goes into the brainstem and tells your brain information. And what happens is that this is like a network. What happens with migraine specifically is this trigeminal vascular system becomes sensitized. You start propagating pain, you start promoting inflammation, and it just affects the brain in an array of patterns. And so migraine is, of course, a neurovascular condition, but it's also being described as a disorder of sensory processing. So think of it this way, like if the inputs don't match the outputs, you have a problem. And it's kind of the same cascade that happens with migraines. That's a really important step. One of the things I talked about earlier in this was just describing like an aura. And an aura, for those of you who don't know what that is, it's essentially a symptom that occurs most of the time visually, where people will kind of see their vision altered, maybe lose vision, especially with ocular migraines. And an aura, you'll kind of see like maybe some patterns or some tracers or things like that that occur visually. It's phasic and it's temporary, right? It's not permanent. And you need to, for sure, without a doubt, make sure that if you're somebody who gets migraines with aura, that you know this isn't a stroke that's happening. And if this is the first time you're getting an aura with a severe crippling headache, then I would tell you to go rush to the ER right away because that's definitely a red flag. And until proven otherwise, that's a stroke. And if it's not, then you're probably dealing with a migraine with aura. But only 30% of people who get migraines actually get auras. And this aura is super interesting. So it's just this wave of like altered activity in the brain. And it's described as cortical spreading depression or CSD. So you can think of it as like a prairie fire that starts from like the back part of the brain and like slowly works its way forward. The weakest areas of the brain will be the ones that become affected. And Dr. Miyazaki does a great job of describing this where like vestibular migraines, the vestibular system or the networks involved in the vestibular system, when that prairie fire is going through, those are probably the networks and areas that become affected and you get vestibular outcomes. Same thing probably with like an ocular migraine or even like a hemiplegic migraine, a migraine where you like kind of have facial drooping and kind of have like similar stroke-like symptoms. Maybe those are just areas of the brain or perceived areas of the brain that are a bit weaker. And so that's kind of the way to look at it. And this usually starts in the back part of the brain, in the occipital lobe. So this area back here that's involved in vision, visual processing, that's usually why most people get auras, is because when that cortical spreading depression is occurring, it's starting in the back part of the brain. And it, of course, inherently affects visual processing. Something to just note and be aware of very much. This is an important aspect to migraine because migraine really is a condition of inflammation and specifically this unique molecule called CGRP. So during migraine attacks, this trigeminal vascular system, this trigeminal pathway becomes sensitized. And it actually starts to release a molecule called CGRP, which is calcitonin gene related peptide. There's a reason we call it CGRP. And this neuropeptide just ramps up inflammation and promotes just vasodilation, so the opening of blood vessels. And that's really where people started looking into migraine and were saying, well, it's a vascular issue. Well, the vascular system is controlled by the nervous system, always has been and always will be. We just maybe didn't appreciate that as much as we did back then. And so what we know is that by blocking this CGRP release, which is what all the new medications are doing, monoclonal antibody drugs that are coming out right now, they all try and block these receptor sites. So when CGRP is released, it doesn't kind of have the lock and key method where it triggers that inflammatory and that pain cascade. So you can think of these medications as almost like a key where you put the key into the lock and you like break the key off inside of it, right? The key is still in there. So I can't put a new key inside. And so you can think of that as like the medications that are being created and presented to the population are essentially these like broken keys into these locks, so that when that key is put in there, you can't actually open the door, but it's occupied. And it's the same thing that happens when the CGRP is released. You want to have that broken key occupy that receptor site so that CGRP can't go in and actually open the door and cause the inflammation. Hopefully that kind of makes a bit more sense based off of the description I gave you. The question we should all be asking is like, why are women hit harder than men with migraine? The ratio is like 4 to 1. 80% of migraineurs are women, 20% are men. So why are women hit more than men? Well, this is a classic question. Yes, there's genetics involved. Yes, there's family history involved. But what they're finding out is that there's leading theories as to why this is occurring more in women. It's usually kind of coming down to hormones, and specifically elevated levels of prolactin. Okay, this can kind of sensitize this trigeminal system that we're talking about in the face, and it can cause increased CGRP signaling, which inherently will promote more inflammation, more pain, and that whole kind of like neurovascular cascade. So unfortunately for women, they have higher prolactin levels, which therefore mean they're probably a little bit more prone to having migraine. That doesn't mean you can just go get rid of prolactin because it's important for so many different aspects of just human physiology. Men have those levels too, it's just not as high. And so something to consider and something just to be aware of for sure, especially as a female. Those are important factors to consider. One thing that I have found super interesting about doing all this research is that migraine shares a ton of similarities with epilepsy and seizures. Now, I'm not saying that they're the same condition because they're not, okay? They are completely different, but they share similar kind of predispositions. So genetically, there are the similar genes with migraines and seizures that share similar functionalities. So when you're genetically predisposed, sometimes in some families, and I've had patients with this, where they're like, yeah, my cousin or my aunt and uncle or my brother has seizures, but I have migraine. And it's like, it's kind of from the same family, but it's not. And so they share some similar genetic risk factors. There's altered neurological processing that occurs with both conditions. There's hyperexcitability of different pathways in the brain. This is also kind of why some anti-seizure medications actually work with migraine patients and for migraine patients. So there's a lot of similar pathology there with migraines and seizures, and something just to be aware of. Definitely something to keep an eye on as later research comes through. But then the last but not least thing is like what makes a migraine is these altered fluid dynamics. So these are like, fluid capacities in the brain. Your brain is suspended in cerebral spinal fluid. It's kind of floating inside your skull. And that's why like when you get a concussion or you're in a car accident, even if you're wearing a helmet or your seatbelt, this movement of back and forth, this shearing and twisting of the brain still happens, right? Even with a helmet that's protecting the outside, it's because the brain is still vulnerable to those forces. And so when you get that twisting or that shearing inside that fluid, you have that violent response and those forces still going to the brain. And so what happens is this cerebrospinal fluid actually moves throughout the day and throughout the night as well. What we know is that people during like deep sleep have increases in the speed of the fluid moving throughout the brain. And there's a thought process out there thinking that that speed and that increased fluid movement is actually taking out the day's trash. And that's what the research has shown. And so if you have altered fluid dynamics in migraine, then what you're actually talking about is not only are you not getting the nutrients to the brain from the cerebrospinal fluid, You're more importantly too not taking out the day's trash. Well, you know what happens if you don't take your trash out? It starts to smell, starts to stink, starts to like occupy the space. That becomes a problem. And so it's the same thing for the brain. And so this is what we know with aging and senescent cells, these zombie cells that occur, is you really want to be able to make sure that your brain can just recycle any nutrients and structural tissues, things like that. But you need to be able to take that trash out. So these are some super important factors that set migraine apart from literally everything else. These are genuinely what makes a migraine a migraine. And hopefully, if you're somebody who struggles with migraine, that gives you a little bit more sense of why you struggle with migraine, and maybe it gives you an opportunity to maybe look into other aspects to help you get through your migraines. So, once again, my name is Dr. Erik Reis. I'm a chiropractic neurologist at the Neural Connection, and I'm one of your migraine mentors here at the Migraine Mentors newsletter. We publish our newsletter every Wednesday morning at 6 a.m. Central Time. And the whole goal of our newsletter is just to help people from a non invasive, natural, and holistic approach try and integratively treat their migraines and potentially decrease their medications or no longer require different surgical procedures, right? So we're not against those. We're all for people finding symptomatic relief, but we're all here for finding the root cause of what's causing symptoms and then doing what we can to help patients update their software. So if you're somebody who subscribed to our newsletter, thank you so much for supporting us. We wouldn't be here without you. If you're somebody who hasn't subscribed to our newsletter or still kind of figuring out like what we're about, then go check us out. Go check out the newsletter. Go subscribe if you want to. We do this every single week. We've done it for the last 60 weeks now. And we're just excited to be here sharing knowledge and information. We've literally distilled 20 years of clinical practice into this weekly newsletter every week to bring the best things that we have available to us to you for completely free. Great to see you. Thanks for joining us. And I look forward to seeing you at next week's episode.